We will now begin our webinar. Thank you so much for joining us today. Our webinar today is Case Studies from the Field, Innovative and Integrated Treatment Models, looking at care coordination and the importance of care coordination and OTPs. A few housekeeping notes before we get started. First, my name is Angela Halverson. I'm with APT Associates and I'm a part of this project. I will be your moderator and your host for today's webinar. Housekeeping, today's webinar is being recorded and will be posted to SAMHSA's YouTube page. All lines are muted, so we ask that you please submit your comments via the chat box. The session will conclude with a brief Q&A discussion. We will take your comments submitted through the chat box and we will pose those to the presenters as long as time allows. Additionally, I would like to add that these slides will be made available and will be sent to all participants on today's webinar via PDF within 48 hours. Welcome to the Care Coordination for OTP series. This is SAMHSA's new 5-part series to be held monthly through August of 2018. Again, all our sessions are recorded and will be posted to SAMHSA's YouTube page. Our next session will be Planning and Creating a Roadmap, Part 1, on June 7th, 2018, from 1 p.m. to 2:30 p.m. Eastern Time. This will be followed by a Part 2 session. Both of these sessions will focus on implementation, activities, operationalization, and other key aspects of actually operationalizing many of the discussions and case study activities that we are talking about here and in our first webinar last month. The registration link for that webinar will be sent via the Health IT Webinars listserv 2 weeks in advance. Please email the email on your page to be added to our list if you have not done so already. I would like to thank those of you who are returning this week. I apologize for last week's glitch in technology. Unfortunately, the GoToWebinar platform was down and we had to reschedule at the last minute. So again, thank you so much for joining us today. I'm very excited that you're back with us. I think we have an exceptional panel today for you to listen to, and I'm excited to see your comments in the comment section. Our agenda today, we will discuss case studies from the field. These presentations will be provided first by Dr. John Brooklyn, then by Allison Noyce and Justine Pope, and finally by Linda Hurley. We will take about 25 minutes at the end of our presentations, and we'll have open discussions with all of our speakers. Again, please post your comments to the chat box, and we will pose those questions to the speakers at the end of our session. Finally, we will conclude with information about our upcoming webinars. At this time, I would like to present to you Dr. John Brooklyn. He is with the Vermont Opioid Treatment Program at the University of Vermont in Burlington. Dr. Brooklyn?
Yes, good morning. Good afternoon, all. I would like to tell you a little bit about a program we've had in Vermont for about 5 years now called the Vermont Hub and Spoke program. Essentially, this program integrates opiate use disorder into primary care, which is relatively unique in the United States. We provide a lot of office-based supports to the primary care providers, but we've created a referral network for those providers if they have more complex cases. And I'm going to describe for you the difference between a hub and a spoke and some of the outcome data that we've had over the last few years. You're going to have available PDF copies of the slides, so I'm not going to read through each slide. I'm going to refer to some of them and perhaps skip over others. Let's see, I got to get mouse control here. So let's see, where are we? Okay, so many people, when they think about Vermont, they think of a very bucolic situation where we have lots of beautiful leaves and maple syrup. But one of the things that we've actually become quite renowned for is the fact that in the state of Vermont, as of September 2017, no Vermonter has to wait for treatment for opiate use disorder. Upon request, people can enter any of the hubs around the state and receive treatment on demand. We were able to completely eliminate the waiting list. As I mentioned, the hub and spoke model is a systemic program developed by the state of Vermont. And we had a project called the Blueprint for Health, which was our overarching program in the state to develop a chronic disease model. And the Blueprint helped design this program by providing teams similar to community health teams for diabetes and heart failure for opiate use disorder, and then created home health services that were provided by both the spokes and the hubs to enhance the billing and the care coordination. This is a slide that shows the state of Vermont, and the red circles with the X's in them are the locations of all our opiate treatment programs in the state, essentially where all the hubs are located. They're relatively well distributed, and in each of the areas, there are oftentimes 2 counties, and all of the providers in those counties that provide spoke services would refer more complex cases to the hubs in their region. So for instance, in the southern part of the state, if you're in Bennington County, you would refer your cases to either the hub in Rutland County or Windham County, but the system was set up so that it was localized treatment. We essentially, people can enter the hub or the spoke system through a variety of means. Someone could present at their physician's office, and that physician, if they do not prescribe buprenorphine, could refer them to another physician, or they could present to a hub for treatment. Many times people present to hubs, and then we determine whether they really need that level of care or whether we think that they could start in a primary care office. Because I'm a family medicine doctor, my bias is that everybody should try to receive treatment in a primary care setting for buprenorphine therapy. However, there are people for whom they're going to need methadone. They cannot receive that in a primary care office, and therefore they have to go to a hub. But you can see here that the variety of places that people can enter the system vary, and there's no one right door into treatment. So hubs were essentially existing OTPs. We gave them prescriptive authority to also prescribe buprenorphine and naltrexone. It's done under a system whereby those 2 meds are billed outside of this typical rate. And we deliver home health services so that the counseling staff and the case managers on staff can do health promotion. There's a series of 6 of them, which I'll show you in a minute. But the most important thing that I want to hammer home is that we are here as a specialty care center, as a referral center. So if someone has a cardiology patient, they'll call the hospital and speak to the cardiologist. We want the hubs to function in that exact way, so that the primary care docs and the spokes don't have to feel that they need to take on very complex cases, that they can send whoever they have who's complex to the hub for stabilization as need be, and then we will send them back to the spoke when they're eventually stable. And this has made a huge difference in the number of people who are actually enrolled in spokes, because the spoke doctors feel much more comfortable in taking care of them, knowing there's a referral network. The hubs actually are all NCQA level 2 status. The one that I work at in the Burlington area actually is the only hub in the United States, the only methadone program in the United States that has level 3 NCQA status. The reason I want to point this out is that if people are thinking about improving the level of care that their methadone programs or their OTPs provide, this would be a model to think about the number of services that we provide. And as you can see here, we list the services that we also provide, which are dedicated to meeting meaningful use standards and consequently becoming more of a medical home model. The other thing is that we provide resources to the community with consultation as need be. And most people in the state of Vermont do not go to residential. They do not go to inpatient programs. They get referred to hubs or spokes first, because we believe that outpatient treatment is ultimately more valuable for this disorder than sending people to residential programming. A spoke is any waivered buprenorphine prescriber in the community. We have a variety of prescribers now that nurse practitioners and PAs can do this. And the other thing about a spoke is this MAT team. A MAT team is provided at no cost to the prescriber, and it is the equivalent of 1 full-time registered nurse and 1 full-time master's level behavioral health specialist. It could be an LADC, it could be a social worker, etc., for every 100 Medicaid patients at no cost to the practice. The reason this was done is that in the various surveys that have been developed over time to look at why prescribers people who have a waiver for buprenorphine do not prescribe. They list a number of barriers in terms of providing care, and we wanted to attack those barriers by providing these services so that the nurse and this what we call the master's level could help the provider manage their panel. And it's divvied up, so if someone has 20 patients or 10 patients, they'll get a certain percentage of that FTE, and the MAT teams are either embedded in a practice in the case of some of our larger practices, or they're nimble and mobile where they'll show up at the physician's office maybe once a week or once every 2 weeks, or they'll provide services to people outside of the office. So there's a variety of ways that they can be utilized, but the most important thing is that the MAT team is kind of the glue that holds it all together and really has helped, as I'll show you in a few minutes, the number of waivered docs increase, and the number of waivered docs increase the number of patients that they treat. And that's fundamentally what's made a difference in the entire model. We used ACA funding, as is indicated here, Section 2703. We got a state plan amendment to do this. For the first 8 quarters when this was enacted, there was a 90-10 funding split from the feds and a 70-30 split in the hubs. And after 8 quarters, we found that it was so successful financially that the state of Vermont is now funding the model on its own with Medicaid dollars through the state plan amendment. This is in essence what we're hoping for. We're hoping to link as many people as possible to a primary care physician, to have the medical office and the OBOT be part of the primary care medical home, and then have the community medical health teams work with the primary care medical homes. So when we think about payment, what we did is we have 2 models. For the hubs, many hubs around the country are rate-based. You get paid a certain amount of money to deliver a certain amount of care. And because we were trying to get the hubs to do more, we dangled a carrot in front of them that said, if you provide an enhanced level of service, if you provide one of these home health services in addition to the basic rate, which would be essentially people dose, and maybe they have an interaction with the nurse, but they may not have any counseling or any case management. If they have, they would get the $353, which is actually below, and that's a monthly cost, below the cost of providing care. But if they got the enhanced rate of $504, it would be above the typical cost of care. So most hubs strive for 90–95% of all their caseloads per month to be at the enhanced rate, which provides a higher level of service. And then the spokes, the care manager and the nurse and the clinician, were embedded at no cost. So there's a certain cost. I think it's $163 per patient to pay for that, but that's absorbed by the state of Vermont plan. As far as spokes are concerned, we have very few cash-only practices in Vermont. Most of our providers are either in solo or group practices. We have a very robust FQHC program in the state of Vermont. We have a very strong commitment to make as many FQHC providers, buprenorphine providers, because we believe that that model is very, very good providing buprenorphine services because of all of the other wraparound services that people can get. We actually have a fair number of the OBGYNs around the state who are prescribers, a few pain clinics, and then a fair number of psychiatrists who also prescribe. So there's a wide variety of providers of buprenorphine. And then in terms of deciding where people should go for treatment, I sketched out a triage tool that I thought would be useful in helping a clinician determine whether the person was too complex for them to handle in their office and whether they should potentially be referred to a hub. And so it is a series of 21 items with a score up to 26. And we believe that when people score up to 10, that for the average patient in the average spoke program, they should do very well in a spoke. But scores above 11, we thought would probably be better in a hub or with an addiction doctor. But it's not absolute. And so if you're a primary care physician and you use this scoring tool and you score a patient at a 15, you may not have a hub anywhere in sight. Then maybe this model doesn't exist. It will give you a snapshot of the different issues that you need to work with that individual so that you're not caught off guard when one of the areas of distress arises. It was loosely based on the Addiction Severity Index, and I'll show you what it looks like in just a moment. see, where's my next slide? So as you can see, this is half of it. Some items are scored 2 and some items are scored 1. The items that are scored 2 are the ones that we have thought over time were the most predictive of people needing a higher level of care, and they include IV drug use, if they had been on medication-assisted treatment before and were not successful, we thought that they may need to be in a hub setting. Chronic pain is always an issue. Cocaine, benzodiazepine, and alcohol use. Those items we thought would be higher because they often predict more dysfunction. The other items you can see here are issues around psychiatry and medical, legal issues, etc. And then the following page looks a little bit more at their social stability, which is counseling. Do they have peer support? Do they have good housing? Are they employed? Do they have reliable transportation? And as far as the reliable transportation, we put that in there because in a rural state like Vermont, you may be 50 miles away from the nearest hub. And so even though you may have scored high, if you can't get to the hub every day, you're most likely going to have to go to your primary care for treatment. So that at least was a marker that people had to think about transportation as a barrier in terms of providing service. In addition, we had a learning collaborative because we know when people take a waiver training to prescribe buprenorphine, they don't become addiction experts. We designed this in concert with Dartmouth College. We provided a number of sessions. We call it Addiction 2.0 and 3.0. There was a learning collaborative for the hubs and one for the spokes. It was based on improving the quality of care. We had a variety of topics such as what do we do about a waiting list? What do we do about people that are disruptive in the practice? What do we do about cocaine use? Variety of topics, and we had this published in the Journal of Addiction Medicine for anybody who wants to review it. But this is a critical thing to make sure that programs provide for their providers so that they don't feel as though they're going it alone. So let's look at a little bit of data quickly before I'm out of time. Vermont was well positioned for a hub and spoke model because we actually for many years had the highest number of waivered physicians per capita. So in 2012, you can see that we had 37 docs who were at the 100 patient limit. And since 2013, this is as of 2017, we increased that number from 37 to 79. So we doubled the number of waivered physicians at 100. You can see that we had people, 169 waivered physicians for 30 patients, but most of them were not prescribing. But as of a very robust training effect, as of February 2017, we had over 200 doctors who were waived. So for a total of 293 physicians who were most likely actively prescribing in the state. And that was very important because you need to have places to refer people out of the hubs. You can see here the growth in the prescribers, and I direct you to the red line. I direct you to the green line. I think one of the most important things is that people were under-prescribing. They were prescribing for 3 to 5 patients. And this shows that now 63, almost a doubling of the number of providers who are prescribing for more than 10 patients, because our goal is to get people to prescribe much closer to their waiver. You can see a doubling in the number of prescribers. So we consider this to be a grand success in terms of the number of patients who have access to buprenorphine. Our waiting list essentially went to 0, as you can see in November 17. And then we looked at cost, and I know I'm getting close to the end. We determined that by 2014, we were already saving 7% of cost by treating opiate use disorder in the hub and spoke. And part of it is shown by this slide. When you look at people who are in MAT, who have opiate, and then you look at people who have a diagnosis of opiate use disorder but are not in MAT, you can see the discrepancy in the total healthcare costs, excluding opiate use treatment. So for instance, in 2016 per capita, $7,900, that's just for medical services, as opposed to $12,500. So the cost savings is significant. And when you add the cost of MAT treatment in there, it comes close to the total cost of the non-MAT cost expenditure. The other thing to point out is that we currently have about 8,000 people on MAT. What that means is that we have 1.6 of the entire population of the state of Vermont on medication-assisted treatment, which is at least double that of the next closest state in the United States. If we estimate that that's maybe 30 to 40% of the total number of people, we may have 3% of our state residents who have opiate use disorder, but we think we're well positioned. And I invite any other state in the country to look at how many adults you have and multiply that times at least 2%. And that will give you an idea of the number of people you probably have to think about treating with opiate use disorder. And most states have nowhere near that capacity. And so building the capacity is a key thing, but you need to know what your numbers are. The last and final slide I want to show is in 2013, 2014, our neighbor to the east, New Hampshire, had 73.9 deaths per 100,000, and Vermont had a decrease of 7.9%. Our rate of death has continued to climb, but at a much less significant than any other New England state. So we view this as another example of why this work is so important. This is our timeline. I'm not going to go through it, but it gives you an indication of what it takes to build this out over a 15-year period. And I'm happy to take any questions.
Great. Thank you so much, Dr. Brooklyn. If you do have questions for Dr. Brooklyn, please post those in the chat box. Wonderful information, John, and I really, really appreciate your time here today. Phenomenal work that you've done there in Vermont. Now we're going to head out to the other side of the country, to Oregon, and I'd like to turn it over to Allison Noyce. She's the Deputy Director at Kodak, and to Justine Pope, who is the Program Manager at Wheelhouse. Justine and Allison, I'm sorry.
No problem. Good morning and or afternoon. Thanks so much for having us. We're really, really excited to be able to present today. I'm going to introduce myself just real quickly. My name is Allison Noyce, as you can see. I'm the Deputy Director for CODA. Something to know about CODA, we're pretty unique in our treatment community. We're a not-for-profit provider. We actually house a full continuum of addictions care, so everything from residential withdrawal management to outpatient services. We have a rather large opioid treatment program that was actually the very first in the state of Oregon. So yeah, we have been really excited to be leaders in our community on medication-assisted treatment, and again, real happy to be able to present today.
And this is Justine Pope. I'm the Program Manager for Wheelhouse, and as well I say thanks for having us here today. So we're here to talk about care management and coordinated systems efforts to address the opioid epidemic. But before we get into collaborative models of care delivery, I'd like to spend just a moment laying the foundation for why they are so necessary. So we'll be addressing the discussion points here. And I'd also like to get on the same page about language, specifically what we use here in Portland, Oregon. So you'll hear us say SUDS for substance use disorder services, and other states may say A&D or substance abuse or chemical dependency. We'll also be referring to specialty behavioral health providers. That means providers who offer both SUDS and mental health treatment. We'll be talking about our coordinated care organization. That's the CCO or Medicaid payer in the Portland area, Health Share of Oregon. And you might hear us say interchangeably MAT or MSR for medication-supported recovery. And what we've noticed is that new providers have really taken to this language of MSR. Setting the stage, we often hear commonly cited statistics around overdose deaths, but the CDC points out that for every one fatal overdose, there are another 80 people who could be getting treatment for an opioid use disorder. And we're in agreement that MAT is evidence-based and the most effective for treating opioid use disorder. We also know that there's a gap in people accessing treatment, both for SUDS generally and MAT specifically. So nationally, there are more people with an opioid use disorder than there is capacity for medication-assisted treatment, and that's the visual treatment gap you can see highlighted here. And let's unfold what a treatment gap actually means, because it's a multifaceted issue. So we just reviewed that MAT is underutilized. It's also not consistently available across settings where people access healthcare. That could be in their primary care practitioner's office, hospital or inpatient settings, or available through corrections health. And MAT is not consistently available even in addictions treatment programs. Nationwide, we're lacking data waivered providers, and recent studies have shown that providers with waivers tend not to treat high numbers of patients, so they can have a lower monthly patient census. There can also be differential access if you live in the city or in the country, and how your insurance payers reimburse MAT. So that was a brief overview of the what. Let's also address the why of this treatment gap, because it's also multifaceted. Barriers range from provider discomfort with the logistics and management of medication, particularly around the time of induction, clinic culture or ideology. There can be staff resistance or misperception of how MAT works or of how effective it is. There may be limited resources or limited access to medical providers. And these organizational barriers are set in a greater environment of stigma around addiction and stigma around the use of medications to support recovery. I also want to acknowledge the tendency to separate our physical and behavioral healthcare systems, both in terms of who holds the benefit, differential reimbursement rates, and even physical locations. So at this point, you might be asking yourself, what can we do about this? And we just heard from Dr. John Brooklyn, really many signs point to Vermont for guidance and inspiration. Vermont is now first in the nation in terms of treatment capacity, as Dr. Brooklyn just described to us. And I'd like to take a moment here to offer thanks to Dr. Brooklyn and Anthony Folland, who's the State Opioid Treatment Authority of Vermont. They have been really supportive of our efforts here in Portland and have made themselves and their resources available to us as we developed our own hub and spoke pilot here. So thank you. And we'd like to tell you about our own effort, which is called Wheelhouse now.
So the Wheelhouse model, which is based on the hub and spoke, which we'll talk about a little bit more, really came about almost 3 years ago now when our CCO came to the behavioral health provider community asking for help. Essentially, they had decided that they were going to strategically invest in the behavioral health providers and opted to target money toward the expansion of medication-assisted treatment. This was a first in the way they wanted to invest in our community, and it was a real first for some high-level emphasis on medication-assisted treatment. So these were dollars that were specifically earmarked for us, and what came out of that was a very unprecedented collaboration between a couple of prominent organizations, CODA, for whom I'm representing, and Central City Concern, an organization who's not here today. We were two organizations who've been in this community for a number of years, but have never actually partnered in a real meaningful way. And what this was us setting ourselves forward in our community to really say we were going to join together and we were going to help others develop their own capacities for medication-assisted treatment.
So here is our program visually, and our local hub and spoke pilot is called Wheelhouse. So what's important about hub and spoke is that it describes a new way of providers relating to each other. It's not just upskilling single providers, but creating an intentional, known, and managed network. And as Allison just described, our community hub is actually the combined program efforts of two agencies. That means we offer a continuum of services from withdrawal management to daily dispensing in our OTP and outpatient settings for care in and around the Portland area. I also want to point out that spokes, and we currently have 6 spokes really want to connect with this system. They selected what they felt most comfortable and confident as they developed their MAT program. And I particularly want to point out that for those folks who use the hub for induction, this is really predicated upon seamless patient movement. So we'll continue addressing how both people and processes in our system design facilitate seamless movement. So Wheelhouse has 3 main objectives. We want more folks to be able to access MAT. We want that treatment to be high quality and patient-centered, and we're really invested in building a high-functioning and integrated system of care.
One thing that I think is particularly important about these objectives is that third objective. This development really became not just about expanding medication-assisted treatment, but doing something that was really unprecedented in our community. We have a lot of providers in this treatment community who do very comparable work, and historically in a very traditional fee-for-service Medicaid environment, we've largely been acting as though we were competitors. What this did was really ask all of us in this community to start behaving like a meaningfully organized network of people. So we're all treating the same patients. We do similar but complementary work. And this was really an opportunity for us to come together and say we were going to work like an organized network rather than a series of separate organizations.
Oh. Okay. Oh. I want to point out some key parts of our collaborative care model. So first, the community hub. Our hub is actually 2 agencies with 9 programs represented, including clinical consultation. We required multidisciplinary representation. So all participating spokes needed to commit a team with executive, medical, and direct clinical leadership. And our own hub leadership team has executive and medical leadership from the 2 agencies, our CCO payer at the table, and a small project team, including myself. Funding. We funded the spokes with attainment benchmarks that were tied to both process and product outcomes. Excuse me. Like Vermont, we've used a learning collaborative model to support network development and the spread of best practices. We've offered individualized technical assistance to spokes as they build their programs, and we're currently readying all providers in the network to use a standardized referral process for better coordinated care. As Dr. Brooklyn touched on earlier, learning collaboratives reduce practice variation and can be really effective for provider and staff engagement. And we have certainly noticed that in our own work. Here you can see an agenda and picture from one of our last learning collaboratives. We have held 5 to date, with 9 organizations represented and around 80 attendees per session. And I'd like to note the importance of those multidisciplinary teams that we required to participate. So on those days, and even in that picture, it's just as likely that you'll see an executive director sitting next to the person who answers the phone at intake, who is sitting with the medical director and counselors from the organization. So we have encouraged and welcomed the participation of all those team players here. And we also make sure to feed them very well on those full days. So for care coordination, we've given you a brief overview of our program, and I want to revisit the Agency for Healthcare Research and Quality's definition of care coordination, which they describe as the deliberate organization of people, resources, and exchange of information. And our program really reiterates and reinforces this organized exchange at multiple levels. And we found the following components support deliberate organization. Something that's really quite important is ensuring shared definitions and common language. So particularly in the world of MAT, what makes a stable patient? How do you define being engaged in treatment? Or even how does your organization understand what makes a referral? Also important are consistent processes, maintaining commitment and buy-in, and having defined expectations. The question we're asking is, how do you know your care is coordinated? How do you know people are getting to the right program the first time and they are getting there smoothly? And this is not just the valuable work of a care coordinator, but really about moving towards more comprehensive and coordinated systems of care. And one example we can discuss, a pretty obvious one around care management, is referrals. So we've created a standardized Wheelhouse referral process. That includes Dr. Brooklyn and Dr. Stacy Sigmund's treatment needs questionnaire, a Wheelhouse referral checklist, a visual guide to select hub programs, and other work aids. This has been an opportunity for us to define our expectations and ensure really clear agreements within the network. And as we've done training on this process, we've asked clinicians what has made a successful referral for them in the past, and we'll come back to this later. So here's an example of one of our visual management aids. This is our hub referral guide. So if a spoke needs to refer a client to the hub, this is how they'll select a best fit program for them based on patient need. And here's also a part of a standardized workflow for transitions of care to the hub. And as we've been working with spokes, they have been quite interested in and receptive of these visual aids especially. And it's really helped us reinforce those shared definitions and consistent processes that are so important to care management and care coordination. You might be wondering, where are we now? We're not fully live yet for all spoke referrals, but integrating our community hub has provided an opportunity for early lessons learned. And one example is increasing the role and function of CODA's call center. not just as a central access point for scheduling, but also for tracking patients, confirming their attendance, and continued engagement back with the referring agency. And we've noticed that there's been a ripple effect across our own hub programs. So as we solidify these processes for spoke referrals, there have been internal program improvements happening as a secondary impact, like increasing rapid access, for example. Let's come back to referrals, because they can be a great example of well-managed and coordinated care, as in they let you know when you're doing it well. Here are some of the responses we received as we were developing our Wheelhouse referral process and are quite attentive to. After rapid access, probably the most common response was the importance of shared language.
And this is one that I really can't stress enough about the importance. We have had projects like this in the past where we have partnered with external organizations and very quickly move through some of these definitions. Say, for example, we all come to the table and agree, okay, when this patient is stable, you'll stop treating them and I'll take them on. What happens though is if we don't really stay at the table long enough to understand what stable means, your stable isn't necessarily my stable. So what we really appreciated about this work is keeping key people at the table long enough to really dive into these definitions and really not make assumptions, which are really quite easy to make if we're not careful. Another thing that I can really stress here is the importance of staying at the table and coming back to the table to really evaluate your own work. We have started to use a phrase of nothing is precious, essentially. Just because we created it, if it's not working, we have to be willing to evaluate that, talk about it, and figure out what we want to do differently.
And I also just want to add on to that even defining a referral, that might seem really basic, but many organizations could define that differently. So knowing someone made it to their appointment, defining who is responsible for communicating that or who is responsible for making another appointment in the case of a no-show, these are all expectations that we're clarifying as part of our work with Wheelhouse. I'd like to tell you about other observations in this work. So there has been really strong group cohesion in our network, and that's very valuable to us. Spokes like technical assistants and the learning collaboratives, they say it has helped to make what felt like an insurmountable effort manageable. And you can see a quote from a medical director at one of our spokes. So again, I want to remind you that the spokes we're currently working with, these are all organizations with new MAT programs. And accordingly, these new programs have been a little more intentional in terms of rollout, which has offered us the opportunity to refine our own pathways and systems that track patient movement. Also, this small pilot is focused on those specialty behavioral health providers. We've seen a great amount of interest from providers in other settings who want to participate in a network like this. And I have to say it's really quite exciting. We're watching systems change, we're watching organizations see themselves as part of a larger system of care, and they want to collaborate and work together. So that's not to say this work is without its challenges. We're still operating with a fee-for-service model that doesn't reimburse care coordination. And this is a new way for providers to conceptualize treatment and access to treatment. So that new way of thinking for folks, we need to continually clarify. For example, HealthShare of Oregon does allow dual authorizations for SUDS providers. So a client could receive hub services for something like induction while maintaining an open episode with their spoke. And we're often reinforcing this message. A continual issue is workforce retention and staffing shortages, especially for counselors, case managers, and care coordinators. And technology, we're working with organizations that have different electronic health records or methods of document storage. Our goal is to not have technology get in our way. And in Portland, we currently do not have a health information exchange. And finally, and quite important, that for folks struggling with an opioid use disorder, this is a generally vulnerable population, and transitions of care are really heightened times of vulnerability. So how can we ensure that client movement is as seamless and timely and as patient-centered as possible? So looking forward, or what's next, besides keeping on doing what we're doing, we're trying to imagine a future network where there really is no wrong door to access MAT, and how might we get there? Accordingly, if we're going to work in other medical settings, how can we ensure we're keeping roles, expectations, and shared definitions clear and consistent? And what external levers can we use to incentivize high quality treatment and transitions of care? This means getting into topics like implementing standards of care or best practices, alternative payment models or value-based payments, and agreeing on common quality improvement metrics. So that's where we are, excited and hopeful for the future. Thanks for listening to us. Many thanks to our partners, including the other side of our community hub, Central City Concern, and our funder, Health Share of Oregon, and also to all of our participating spokes. We're honored to have the opportunity to be included in this presentation and to tell you a little bit about our work, and we look forward to answering any questions later.
Thank you very much, ladies. We greatly appreciate your time today and your information. I think it's a great complement to this webinar, and I think it's exciting to see what's happening in Oregon. Now I'd like to turn it over to Linda Hurley. She is the President and CEO of Kodak Behavioral Health. She is out in Rhode Island, so we're going to move back to the eastern side of the country. Linda.
Good afternoon, and I think it still is good morning somewhere, correct? Thank you so much. I'm also, much like Dr. Brooklyn, I think at this point there'll be some slides that I may skip or not give as much focus because they were so beautifully explained in the two prior presentations. So I want to thank you all for being here. And I have just, there we go. Oh dear, excuse me.
Linda, are you there?
I am here. I'm having, there
Okay.
we go. I was having trouble moving the
There.
slide. It just went, so we're good. I apologize.
Okay.
So the program here in Rhode Island that Kodak Behavioral Healthcare has been fortunate enough to be participating in is that of the Rhode Island Department of Corrections Enhanced MAT Programming. And I think when we look at the rationale for doing this, our program is actually was the first program to provide all 3 medications in prison to all patients in need. And if you think about the broad brush on that, I think it's fairly remarkable. This Andrew Joseph from the Boston Globe said something interesting. That's why I included this here, that medication-assisted treatment is considered the most effective therapy for opioid addiction. And so providing it is the right thing to do from a public health perspective. And if it can help reduce recidivism, it's the right thing to do from a criminal justice perspective. The statement provides a strong and clear community rationale for the collaborative treatment approach reflected here in Rhode Island prison system. As providers, I think we can take this statement one step further and say, in quotes, if MAT can help one more individual walk this earth with a little more peace, it is the right thing to do from a human perspective. And fortunately for us here in Rhode Island, the medical director of our Rhode Island Department of Corrections, Dr. Jennifer Clark, has this approach.
Linda, real quick, you're fading in and out. If you could either move a little bit closer to your mic and speak a little bit more clearly, you're kind of going in and out, so it's really difficult to hear you.
Okay, is this better? How's this?
That's much better, thank you.
Okay, my apologies again. Just as a piece of humor here, we had everything straightened out, and there's street work being done that started about 10 minutes ago outside the window, so I'm going to keep speaking loudly. So the program had very basic goals. It was to identify those that were incarcerated in need of treatment. It was to initiate MAT for those patients in need, to increase retention in treatment post-release, which was remarkably critical, and the ultimate goal, of course, was to decrease mortality. Here in Rhode Island, in 2015, almost 25% of the overdose deaths that occurred in a population that had recently been incarcerated. They were remarkably high highly vulnerable population. So in addressing this the program that was created in collaboration between Kodak Behavioral Health Care and the Rhode Island Department of Corrections, what consisted of a comprehensive reentry services that coordinate care within the prison and also in the community. So that care coordination of the OTP health home model that was spoken about earlier and the Center of Excellence model, the hub and spoke model. We have both of those here in Rhode Island with our OTPs. So a full array of wraparound services are available to individuals as they re-enter the community. All 3 FDA-approved medications are provided to inmates through a co-located OTP, including a dispensary within the prison, which is lovely because it allows for real-time response to any medication. The medication is provided to those being committed and also to those with opioid use disorder history pre-release. We'll talk a little bit more about that. Counseling is integrated into daily schedules. This may not sound innovative, but inmate scheduling is varied and complex and historically has often precluded these services. So this was no small feat. And again, understanding the challenge of comprehensive, seamless reentry. I know that's referenced twice because of the importance. So there were basically these 5 innovative objectives that define the program. So what makes it different? Methadone is provided as a medication. Daily doses of medication are provided through the OTP, the DEA-registered OTP that is on site on the campus of the Rhode Island Department of Corrections. Buprenorphine, also daily doses of medication are provided through that OTP, that pharmacy, that dispensary. And naltrexone is provided by the DOC pharmacy. This schedule of dispensing and or administering medication is an example of coordination of care for inmates between the Department of Corrections and Kodak in order to coordinate effective care. We look at efficiencies. So with corrections more easily dispensing or administering the non-scheduled medications of naltrexone and the DEA-registered OTP that's Kodak providing the scheduled medications. And some of these things really may sound simple, but it really, what makes the program run smoothly is the focus on these efficiencies and very clear communication. So our history here in Rhode Island has been innovative but limited. We were, when looking at this history, you'll find that the administration actually was always innovative, comparatively speaking, to the rest of the country. Historically, methadone has been provided for over 20 years. In 1994, for pregnant and HIV positive inmates, people being committed. In 2000, for a medically supervised, more humane withdrawal for those who were receiving methadone in their communities. In 2016, longer-term continuation of medication, methadone, up to 6 months, and we're actually now at a year. Buprenorphine began only in the women's division in 2016. It's now in all buildings. Naltrexone, 2015, at patient request and was available in depot formulation. This now is available to all patients. And when we say in all buildings, because Rhode Island is so small, we have a system that we have one prison and it's on a campus and each building is at different levels, minimum intake, high security. Across the board, all patients have the opportunity to initiate and become stable on these medications. This is just an interesting outcome as we've been looking at the program. The program began about 24 months ago. And if you look, at this point, there are a little over 3,500 inmates And of those, close to 350 are receiving medication-assisted treatment for opioid use disorder. Primarily, folks around 60% prefer methadone. Buprenorphine comes in at around 40%. Again, this is patient choice with medical direction. And Vivitrol is not the favorite, and we don't have a very strong follow-through rate with Vivitrol at this point. But what is interesting here is that that's 10% of our population is receiving medication-assisted treatment here in Rhode Island. 25%, based on the screenings that have been done so far, report a history of opioid use disorder. So in addition to providing all three medications, another difference in this program is it's provided to three different groups. Those who have been receiving medication-assisted treatment in their communities from a provider, they become incarcerated and their medication is maintained for up to a year. And if they're going to be sentenced for longer, then the withdrawal regimens that are, like I said earlier, much more humane are completed. Another population are those who, at commitment, when they enter the prison, if they report or exhibit symptoms of opioid use disorder and request treatment, our goal is within 24 to 48 hours, they will be screened, assessed, and receive their medication. The third is the population who have been sentenced and request induction on a medication pre-release for safe reentry. This is our most controversial, I think, population due to the confusion in the definitions of physical dependence on an opioid and an opioid use disorder. Clearly, the patients no longer are physically dependent, but an example recently, a patient who was reporting that he was going to be released in 3 months, and his statement was, "I'm already having dreams and cravings, and I've made plans for use when I leave. I need help." So we initiate, stabilize, and connect this population to a provider in the community at release. Screening everybody upon commitment and prior to release, and assessing all those whose screening indicates MAT is effective is a critical objective. Expanding care to all those for whom MAT is indicated, and providing, this is remarkably important, providing seamless community transmission through enhanced discharge planning and community care coordination. And I'd like to note here that this seamless community transition involves MAT-specific behavioral healthcare professional discharge planning, so that when individuals leave, when they are released from the prison, they are directly connected the next day to MAT services and other behavioral health care services. And I know these are very straightforward objectives. The challenge is in meeting our goal of care coordination, not just through the established relationships, but through the systems integration. This required a great deal of system integration. This is a reiteration of the three objectives, the goal being decreased mortality. I have to smile when this slide comes up. Dr. Tracy Green is an epidemiologist here in New England, and she evaluated the data from Drs. Clark and Martin here in the Prison Project to reflect the program's efficacy and its impact on statewide and population-specific mortality. So we looked at the mortality of opioid overdose in Rhode Island from January to June 2016 and compared it to January to June 2017. And then compared opioid overdose mortality, general population, to individuals with recent incarceration. This was published, by the way, in April of 18, volume 75, I believe. And this is the outcome. What is most important is what is in the yellow box. There was and if you look at the relative risk reduction, 61% decrease in mortality in this population. 61% in, in an 18-month period of observation. I'm sorry, I'm struggling for words here. I still get moved by this. If you think about overdose death has been decreased 61% in this highly vulnerable population. That's just not seen in medicine that quickly, So in speaking about incarceration, what truly was once a barrier to recovery is now the intervention. Care coordination for a highly at-risk population was created between systems with historically different missions. So here we're looking at a little bit of implementation. The program, the objectives, and the goals were just described. We're talking a bit about how we did it. I included this slide because Kodak Behavioral Healthcare has 8 sites in Rhode Island, 7 of which look like your dentist's office or a historic mill. And we are having our highest level of hopefully continued successful rates coming from the prison. I think the physical metaphor of the difference of the missions is right there. Challenges to creating this collaborative model of care coordination. One is culture. From an opioid treatment perspective, we're looking at a culture of security and safety on the prison side or rehabilitation. How did we integrate the missions to have a successful program or a program that's successful for those receiving care, and how do we maintain it? Other challenges are non-traditional costs. For example, there are shifting implementation timelines, there's politics of funding. There was a great deal of cost and revenue vacillation impacting projected budgets for this project. So when an opioid treatment program collaborates with a system that is somewhat remarkably different from what we are accustomed to managing, it requires a great deal of flexibility and thoughtfulness. Staffing competencies beyond the science. Individuals who are working in the prison need to have strong interpersonal skills and professional maturity. They need to understand that they're ambassadors as well as clinicians, that flexibility must be the norm, and that not all staff or inmates welcome their presence. There's a culture change involved in patient versus inmate, and moving that to patient and inmate. And there's a process or logistical shift for OTPs when working in a prison. An example would be internal security schedules impact on all staff utilization. So the established linear processes have been challenged and require creativity to reconcile and continue to require creativity and tact. And thoughtful timelines, understanding that creating this integrated mission in order for the program to work takes time. These again are also simple, straightforward, but the creation and implementation of strategies was complex and required a great deal of time. Challenges continued. The stigma attached to substance use disorder, to opioid use disorder, to medication-assisted treatment, certain medicines. Methadone remains shrouded in stigma in this particular environment. Stigmas attached to the providers, and it's attached to incarceration. So this population really suffers greatly, as do those that are courageous enough to try to provide it. this is just a flow of, and it represents two things. It represents very simply what the product looks like, but it also represents the remarkable collaboration that needs to occur at each step to provide coordination of care. At commitment, for example, there's security, there's Department of Corrections medical, there's wardens, there is the treatment provider, which is Kodak. And with every step, as you move down at the medical intake, we now include Kodak physicians, the challenges of release. And this is the team, the integrated team that makes this happen. The medical director, Dr. Jennifer Clark, is absolutely remarkable. Dr. Susan Hart is our medical director here at Kodak. And you can see that we have a full team that has begun to integrate. We've been doing this for a while, but the integration is actually starting to happen into the environment. Excuse me. So in addition to these collaborations for care coordination, there was also invaluable community collaborations here in Rhode Island. And, oops. Let's there, okay. And interdepartmental collaboration. So in order for the system to work, we know what the project looked like. Now we're talking about implementing the system. There was interdepartmental collaboration that had to occur at the Rhode Island Department of Corrections, in addition to incorporating Kodak into that. And again, Dr. Clark was brilliant in bringing together all the stakeholders frequently to respond to a department's concerns in real time. And I believe that to be the linchpin to success. We met weekly for well over a year, and it didn't matter if we were talking about the times that people would receive their medicine. Didn't matter. It didn't matter who the concern was coming from. They were all important and all considered essential stakeholders. And I really believe that that is what has really supported the success. We had invaluable community collaborations, which I started to reference earlier. And excuse me, I'm so sorry. So, of course, it was Kodak and the Rhode Island Department of Corrections, the Governor's Overdose Prevention Task Force. I have a minute here. Brown University is maintaining the integrity of our data for us. And the Rhode Island Department of Behavioral Health, Developmental Disabilities and Hospitals gave us a suite in the hospital on the campus for an outpatient center of excellence, so that when people are released, they can simply walk down the hill. They don't even have to have a bus. They can walk down the hill and start receiving services. We will have data on the success of that in August. I was just putting here, basically, it sounds so complicated. Our job is to enroll and treat people and make sure that their treatment continues seamlessly. That speaks to the critical point of reentry, and we've spoken about this, so that at reentry, someone can move into an OTP health home, they can move into an OTP center of excellence, office space, whatever is clinically indicated. But the role of these specialty discharge planners is to make sure that all of these pieces are in place. Again, this is sort of this is an overview where we had to have intra-agency systems change for Kodak as an OTP, intra-agency change for the Rhode Island DOC, and that came together for that kind of conscious change leadership in order to integrate and create the project. And it was all supported strongly by the state, both financially and from a regulatory perspective. We learned two more things: the importance of care coordination basics about relationships, communication, excuse me, established credibility, which is extremely important. Established credibility and interagency trust. When you begin to create that, it has to be garnered, guarded, and nurtured, because the players, through attrition and other things, change. So care coordination basics and planning. Lastly, my favorite slide. This is replicable. And if you take nothing else away from this presentation, besides my inability to speak, 61% decrease in overdose death in this population with the changes that I have described. So thank you very much.
Thank you very much. I appreciate your time today. And the slide here, the 61%, this is incredible. And I think all of our presenters deserve a big pat on the back for the work that they're doing in each of their states around treating this very important and vulnerable population. We do have some questions that have come in through the chat box, so I'm going to direct my first question to Dr. Brooklyn. Dr. Brooklyn, I believe you addressed this, but if you could just expand a little bit on who pays for the MAT teams in Vermont.
Yes, thank you. That's a great question. So the MAT teams are part of the Blueprint for Health, which is a division of the state government that oversees our chronic care initiative. And if you think about any community health team such as that for diabetes, where maybe there's a dietitian, nutrition expert, a health coach, or in the case of congestive heart failure, you may have case management. It's the same exact funding source. It comes out of a pool of money that's dedicated towards medical home and meaningful use programs. So it's a direct line item in our state budget out of our state plan amendment that we have determined is cost effective in terms of reducing the overall costs of opiate use disorder. And I think I mentioned, I think that the fee is, if I'm not mistaken, $163 per person per month is put into the pool. And we have right now the equivalent of 72 full-time equivalent nurses and master's level clinicians around the state who are drawing down that funding to pay their salaries. The money, when it's distributed, is distributed to each county. There's a MAT coordinating team in each county, and in some cases it may pass through a large hospital setting, or it may pass through a mental health organization. The reason this is important is that we have had people who have gone to the MAT team leaving primary care or some of our hubs because the salary is much greater because it's funneled through a larger organization. And that actually created some unanticipated challenges where we would lose clinicians at a hub so that they could become MAT coordinators. And so there was a little bit of a dance around how do we, adequately pay the cost of both services. And we've worked out a little bit of a reimbursement model. But the bottom line is that it was funded through state and funneled through the local administrator for payment to the staff.
Great, thank you. And I think financing is a question that comes up often. Many providers who look at expansion of services and increased access to care often struggle with how to get that financed. Justine and Allison, would you care to address any financing challenges? I know you talked about not being funded for care coordination services out in Oregon. Can you talk a little bit about how you're financing and funding the work that you're doing?
Yeah, absolutely. I think, so as we mentioned, the funding that we got from Health Share of Oregon really had from the very get-go a clear eye on sustainability. At least from Health Share's perspective, they knew they weren't gonna they weren't going to create a system that meant they were then committed to funding something ongoing. So that in our circumstances, the money really was incentive. So the money was dedicated to the time and the administrative resource that CODA and the CCC would need to either add positions to manage this work, to map it out, and to develop the model. And then what we did was we took a large portion of the money that HealthShare had offered as incentive and then offered it to the potential spoke organizations, mostly to just encourage them to be a part of the project. We knew we weren't going to be able to fund positions on an ongoing basis the way that the Vermont model had. So what we did with the money was we proposed it really be very low barrier to them. The spokes really had the opportunity to kind of spend the money internally however they wanted, as long as it was really in support of them developing their own MAT programming. So it gave them flexibility to have those executive team members dedicate full days, at least once a month, to these learning collaboratives. It gave them some startup costs or some training funds should they want to use it that way. But we definitely, in the very beginning, as we were trying to decide how to distribute all this, we really did struggle with the idea that we weren't giving people money to pay for positions and we weren't changing the reimbursement model in any meaningful way. Our hope is to really end this project, or at least the sort of funded part of the project, with a recommendation for how they might pay providers like us differently. So we're investing some of our resource now into coming up with some proposals for alternative payment strategies.
Great, thank you very much. And Linda, in the Department of Corrections model that you were talking about, can you talk a little bit about some of your financing challenges and issues?
Yeah, we're really fortunate here in Rhode Island. The dollars for this project came out of our state budget. So it was the governor and our legislators, and went directly into our Department of Corrections budget, who for the last 2 years have become are remarkably committed because of the outcomes we're seeing. So from an internal perspective, for the state, it seems that this is not going to be an allocation that's going to go away anytime soon. From an OTP perspective, the challenge, of course, is when we contract to provide these services is really in what I've talked about before, around the changing need and trying to project an accurate budget, thinking about what could happen. And you can imagine, for those of you that have written budgets to respond to an RFP, trying to incorporate that is very difficult. In terms of reentry, the individuals who are reentering the community are going back into or entering either centers of excellence or health homes, so that we in Rhode Island have bundled rates for those services that provide all those wraparound services that are needed. So at this point, we have a lot of sustainability. The state, both the Center of Excellence and our OTP health homes are also funded through state plan amendments.
Okay, Linda, thanks. As a question specific to you, Linda, did you have to overcome regulatory hurdles to have controlled substances stored inside the facility?
We did not. There were, actually, we had a great deal of collaboration. My biggest concern, of course, was the DEA. And when they came out, their response was, there's probably not a more secure site. So we did have to have a specially secured room within the secured facility. Right now, I think our biggest challenge, and I'd save some of the challenges for a later webinar, but one of our biggest challenges is, in order to remain an DEA registered, CSAT approved opioid treatment program, we need to be accredited. And when you're trying to provide treatment in a correctional facility, there's not there you don't have the same freedom of record sharing, you don't have the same freedom of access to the individuals. So we're trying to find a way to become accredited and maintain our CSAT status. And there really, at this point, doesn't seem to be a model out there. But that's our hurdle right now. So we're looking to what's going to happen in the future.
Okay, thank you. And as far as other regulatory questions, I know 42 CFR for a lot of folks working in the behavioral health field can sometimes feel like an obstacle. It can feel a bit challenging to coordinate and integrate services across systems with 42 CFR and the consent requirements and privacy requirements. Would the team, Allison, perhaps maybe Dr. Brooklyn, you could address it initially. How does 42 CFR, how did you address any 42 CFRs and some of the integrated systems questions that you have?
Alice, you want to go first, or?
I was waiting to see if you wanted to know. Actually, I think it comes up a fair amount with our group. I think where we have, in this moment, good fortune is that because our model focused so specifically on existing behavioral health providers, it was a group that already really has managing 42 CFR expectations pretty well embedded in their practices. So we're just so accustomed to just get a release of information for everything that it comes up as a question periodically, but hasn't felt insurmountable. We and John probably has better experience in this than we do, but we're thinking about, as we grow, if primary care is sort of our next big hurdle, I'm much more confident that we'll need a better answer for how to manage 42 CFR with that group than the one I just had.
Well, this is John. Let me take a crack at this. If you recognize that this is not an individual behavioral health network, but the entire state, it was a bit daunting to figure out what to do. So what happens is that if someone presents for services at a hub, part of what's required of them, because we operate as a quasi-specialty center medical home, everybody who enters has to sign what we call a MAT consent form. And what that means is that they have to identify who their primary care physician is. And to our credit, we have about 85% of all individuals who have opiate use disorder have a primary care physician. So that's pretty high penetration. But they have to sign a consent form so that we can communicate. And the reason for that is that we're going to be checking the prescription monitoring database. We're going to be coordinating care with their primary care physician. And we're going to want to make sure that we, at some point, have an understanding that we're in the game with them and not siloed out as many methadone programs have traditionally been. They've kind of been standalones and not involved. We are an integral part of the healthcare system in Vermont, the hubs. So the MAT consent form is signed, and in all my years of doing this, I think I had one individual who didn't want to sign it, and that was because he didn't want his primary care physician to know that he had an opiate problem. And so we had to do a little, talking around that, and he eventually consented. So that allows us to communicate back and forth. That's the first thing. The second thing is that the treatment need questionnaire, when we had a large waiting list in Burlington, in fact, we had a waiting list of almost 2 years for people to enter the largest hub in the state in Burlington. We created a triage team where we would meet every week and we would go through every applicant who was applying for services and look at their treatment needs score and trying to figure out where they needed to go. We created a multi-party release so that all of the different parties involved who might be accepting that spoke referral or that hub referral were on the release. And we have a tradition of doing that because we also have a pregnancy program called CHARM, where we integrate the care of the pregnant women and their babies and their opiate treatment. And that model has served us well. So it's an integrated multi-party release that they sign. And so I think what I would suggest in communities that are trying to do this is get all the parties at the table, maybe get some legal rep. It took about 8 months to get the multi-party release signatories on it from all the different organizations, but ultimately it allows you to work within the confines of 42 CFR, and you don't hit those bumps, those walls, those roadblocks, those silos that so many places around the country have, and you're really integrating substance use treatment into the mainstream medicine, which is really what it's all about.
Great, John. Thank you very much. One more question, John, specifically for you. Can we learn a little bit more about how non-chemical dependency treatment services can be integrated into hubs? And this is coming from an individual who says he's an OTP provider in New York State, and they have certain regulations about what kinds of services can be offered and for which they can receive reimbursement for in the APG codes.
Sure. So part of the health home services, and I guess I neglected to put a slide in there that indicated them, it's health promotion, it's case management, it's family and individual services, it's transition of care, it's health quality improvement. So let's say for the sake of argument, so the other thing is that our funding lends itself to being able to provide those services as it's part of the bundled rate. So if we get a bundled rate that allows us to have hired a case manager, that individual can work on things like helping a person get transportation, working with them on how to create a resume, working with them on getting a job. We're also connected to all the recovery centers in the state. Each recovery center is located near a hub, so we'll often have volunteers from the recovery center come to the program to help people engage in different kind of recovery activities, whether it's an outing, something of that sort. So there's very little that we can't provide at a hub because of the way that it's structured. In fact, the more services you provide, the better the enhanced rate is. So if you were an OTP that didn't have that kind of situation, you are fairly limited in what you can provide. And to bill outside of that, you would have to have either a master's level clinician, I guess it depends on the state, or even a medical person, perhaps billing some incident code for whatever you're doing. And again, it depends on the funding model. But the model in Vermont was really based upon making these OTPs medical homes where we could even provide primary care if we needed to, but a wide variety of services can either be provided or voluntarily provided by outside arrangements with other agencies.
Great, thank you. I hope that answers the right, I hope so too. Well, we are coming close to the bottom of the hour, and it doesn't look like we have any other questions at this time. I do just want to say to our presenters, thank you very much for joining us here today. I think the information that you've provided is very valuable in talking about the specific experiences that you've had in your own states. And I would invite our participants to join us for our next webinars coming up in June and July. We're going to break down more specifically how to go about actually doing and operationalizing some of the work that we've heard Dr. Brooklyn and Linda Hurley and Allison and Justine talk about. We're going to really look at how to make that happen, sort of a step-by-step action plan for engaging in and developing care coordination through the OTP system. So you'll see there on your slides in front of you, June 7th is our next one. It's from 1 to 2:30 p.m. Eastern. We'll focus on choosing partners, setting goals, and strategic planning. And then we'll follow that up with part 2, July 12th, from 1 to 2:30 p.m. Eastern Time, focusing on financing mechanisms, regulations, and technology. All three topic areas I know are incredibly important and tend to raise a lot of questions from providers who are providing these services. We will send the registration link via the Health IT Webinars listserv, and you see the email there on the screen in front of you, healthitwebinars@aptassociate.com. If you would like to be added to the list if you are not already. Again, all of our sessions are recorded and will be posted to the SAMHSA YouTube page. And again, these slides will be put into a PDF and will be distributed to all participants on today's call here within the next few days. Again, I would like to thank our presenters for their time today. I'd like to thank our participants for joining us. Despite the scheduling and technology glitch we had last week, I'd like to thank you for coming back to listen to our presenters today, and I hope to see you on our next webinars. Thank you very much, and everybody have a great day.